So I hope that you managed to connect. We are going to start with all of you. I know that we have a lot of connection which is are coming now. 46 countries are representing here, and we have also many Chinese surgeons connected with one connection. So I would like to welcome all of you. I'm Alexandra Duval. I'm the VP Marketing and Communication for PETERS Surgical, and we are very happy to start this webinar on the behalf of PETERS Surgical. This webinar will be dedicated on the challenge on mitral valve repair and in open surgery. We are so happy to welcome Professor Obadia and Dr. Grinberg, which are going to facilitate this, this webinar. This webinar, hello, this webinar will be more or less 30 to 40 minutes of talk, divided by 3 parts. One which is more on the exposure, the second one which is more on the lesion assessment, and the third one more focused on annuloplasty. And we would like that this webinar will be definitely interactive. This is why you are more than welcome to, you are in mute, but to ask your question via chat. And we will make a short break after each part to answer to the question that you may ask to our speakers. So Professor Obadia and Dr. Grinberg, you are coming from the University Hospital in Lyon, and you are very high expertise on mitral valve repair. So I leave the floor to you to start the session. Thank you so much.
Well, thank you, Alexandra, for this invitation. And we also thank your institution, I mean, PETERS Surgical, for setting up this webinar. The format we have tried to design with Daniel, who is a young surgeon working with me in my department, is a discussion, and as a consequence, you will have, as a young surgeon, I imagine that the majority of you, the people attending this webinar, are young surgeons. So we will try for this session to focus on the basis of mitral valve repair. Daniel will present the way we imagine the treatment of my mitral valve in my institution, and we will have a discussion together all along the presentation. So there are 3 parts actually. We have tried to focus on very simple things, because one of the most important things, this is true for any kind of surgery, is the exposition. You cannot do a good repair if you are not well exposed. And there are different ways to address the mitral valve. And this is why we will have to discuss this in the first step. And then we will discuss the assessment of the mitral valve and also the annuloplasty. So we will not go into the details of mitral valve repair. Maybe we will have another webinar, and we will modify the format according to your suggestion. But for today, we want to focus on it's a kind of introduction. And this is why we focus on the main, thing of mitral valve repair. So Daniel, you can start right now, and we will have the discussion all along the presentation.
Okay, hi everyone. Just to introduce the service just slightly more, this is where Lyon is in France. It's the second town of France. In our institution, we're doing 1,100 surgery under CPB and other cases of upcap surgery. And we have a program of minimally invasive mitral valve surgery that was started by Professor Obadia in 2005 with more than 100 cases a year. Which represent a total of 1,500 cases performed so far. And for almost a decade now, or more than a decade actually, we also start a program of structural valve treatments, with initially the treatment with the TAVI, and for almost six years now, the program of MitraClip, following by the program of Neocord, Tendyne, and Incisions that's gonna start soon. So we we try to reach an expertise in all the fields of mitral valve treatment. So without waiting too long, so this is a plan that was presenting to you. So I'm going to start first with the mitral valve access and exposure. So there's a lot of ways to access the mitral valve surgery. The first one was the standard sternotomy, and in the early 90s, the right thoracotomy was described, obviously, and so with time after time we started from this very central access that was providing us a very good access to the heart, the medium sternotomy, then going to the right thoracotomy with obviously all the tools for celioscopy, basically, to a whole percutaneous access. And here you see a patient that just had a MitraClip, and this is basically the access that was required for this patient. So Professor Obadia, can you explain us why you decided to start this program of minimally invasive surgery almost 15 years ago?
Well, as you know, in every kind of surgery, it is always the same story. The incision have decreased step by step. This is true even for neurosurgery, for orthopedic surgery, for the gallbladder surgery, and any other surgery of the abdomen. So this should be the same story for cardiac surgery. So I have tried to be involved in this program very early. The only problem today is to decide which patient deserve to be treated through a sternotomy, through a minimally invasive approach, or through a percutaneous technique. And the most difficult thing is to think in the right direction, not to think upside down. What I mean is that you always have to keep in mind that the goal is to get a perfect result. So the perfect result is the goal, and the approach serves the result. So if you can reach a perfect result with a percutaneous technique, you can do it. If you can reach with a minimally invasive approach, you can do it. But sometimes when you have, for instance, a complex endocarditis with multiple disease, there is no other way than using this sternotomy. So this is important to think in terms of results. The main mistake should be to decide, I want to do an approach, and then I will see which will be the result. So the result is the key, and the approach serves the result. This is the way we have to think.
Okay. So I think other elements of answer and what justified the approach of minimally invasive surgery, I guess, was that basically in terms of anatomy, we are it's pretty straightforward actually. When you see this CT scan, you understand what you try to reach with the sternotomy access, what you try to reach with the minimally invasive access. So this, I guess, this was a good answer and because this access provided super well a view on the valve.
Absolutely.
And this is just few pictures of the patients that we operate on like few weeks ago, and the right in the right hand side you can see a male patient that was and this was the incision. So basically there's almost no incision that can be seen, and we have for this patient obviously an aesthetic advantage, but also patients are also able to go back to work super fast, going back to their previous quality of life, and also I think we have less transfusion in this patient, right?
Okay, no, you can go ahead. Yeah.
Okay, we're going to speak a little bit about the heart incisions. So there's, as you know, there's basically two ways to access the mitral valve surgery. With a sternotomy, with minimally invasive surgery, it's always a left atriotomy. But with the sternotomy, there's two ways to approach the mitral valve. The first one is the left thoracotomy, after dissection of the interatrial groove, the Sternotomy groove. As you can see here, first the right atriotomy is pulled forward to identify the groove, and then the incision could be done in front of the two pulmonary veins, and thanks to dedicated setup and tools, you can have like this one, you can have a perfect access on the valve, but you need to have a dedicated tool to provide a good access to the valve.
Yes, we have to say that this is a drawing, and when you go through sternotomy with this approach, it's not always easy to have this kind of view on the mitral valve. This kind of view is possible with the minimal invasive approach because you go straight forward from the right side of the thorax, and then you have a nice exposure of the mitral valve. This is one of the main advantages of mini-invasive approach, because mini-invasive approach is not only to be for aesthetic reason, it's also because when you are used to, you have a better exposure of the mitral valve. But today, we speak on the basic, and we don't want to go too far on minimally invasive approach. But if you do it through sternotomy, with this kind of approach, through the groove of between the two atria, it's not that easy to get this kind of view. This is why when we do sternotomy in my institution, we prefer to use a different technique. Daniel is now very experimented with this technique because this is a technique we use in my institution, and he can describe it.
So the alternative of left atriotomy is a transeptal approach, what we call the Guérodon approach. So for this, it's a pretty easy approach, but there are a few elements that should be done. So the incision starts with the incision of the right atrium. Usually at this level, we try to keep some distance with the right ventricle. I will explain you why later. And so then you obtain this view of the right atrium. You have the tricuspid valve. We'll see it. There's a short movie that we'll present you afterwards. So you see the tricuspid valve. So it's also allowed to perform any gesture on the tricuspid valve. When you have this exposure, you see here the foramen ovale that has to be opened. And with the opening of the interatrial septum, you obtain this access to the mitral valve, and you will see it in the movie that is just coming. Usually, we don't stop the incision of the right atriotomy just here. We expand it toward the top of the heart toward the left atrial roof, and we can get a perfect view.
Well, I just want to add one element. Here you have, excuse me, come back.
Yeah.
Here you have the view of the transeptal approach. You can do this and the incision just on the septum. So you don't have to go too far on the top. But this is what you can do when you have a very large atrium. And this is probably the case in India or in Indonesia, in your country, where you have rheumatic disease with huge atria. And in these instances, you can just open the septum so that the incision is less important. And it's often enough to have a rather good view on the mitral valve, particularly if it is for doing a replacement instead of a repair. Well, it's much easier to do it. But if you want to do mitral valve repair, and today the trend is to operate the patient earlier and earlier, we need to go far on the top and to extend the incision. It's not only a transeptal approach. The Guérodon approach is an extension of the transeptal approach, which allow a very good exposure of the mitral valve, whatever the size of the both atria.
So here is the movie of one procedure. So here we represented where should be the incision of the right atrium, there are actually pitfalls that should be taken in consideration for the opening. When you do that, you are super close to first the right atrium, and close to the right coronary artery. So you might have in mind that you should keep some distance here with the right ventricle to avoid, if you have any problem, to avoid taking a suture the right coronary artery. And other pitfall is that you are going to go towards the within the left atrial roof, and you should keep far from the aorta for exactly the same reason. You don't know exactly the quality of the tissue, and if the tissue is shredded when it's taking a suture, you will need to have some tissue, and you have to keep some tissue far from the aorta. So when you do this kind of approach, keep in mind that you have to stay far from the right ventricle and also far from the aorta. So here you've got the opening of the right atrium. We also stay far from the superior vena cava, because we know that here we'll have the sinus node. Sorry. Usually we open the right atrium during the cardioplegia. So here you can see the coronary sinus, where you've got the sucker here trying to get all the cardioplegia liquid. So in this case, we also were doing a tricuspid repair. So just to show you that with this incision, you will be able to do both tricuspid and mitral surgery. So we use stitches to provide the good access. And you can see here that you can explore the tricuspid valve in a great manner with a great exposure. This is pretty standard for tricuspid surgery, and we're going to go far on that because this is not the topic of the day. But again, you have the classical pitfall of the tricuspid surgery with what we call the Koch triangle, that allows you to know where the conduction pathways are and what you should avoid when you do your tricuspid repair. Here you've got the foramen ovale that is easily seen, and to get access to the mitral, it's going to be open vertically. First here toward down, and then toward the top of the incision toward the left atrial roof. And here you can see that we open the left atrial roof, and we try to keep at least 1 centimeter away from the aorta. And here you go towards the left appendage that is here taken. And we often perform the closure of this left appendage when we are performing the mitral surgery.
And the ablation too, of course, if we have to.
Okay, we use here stitches to provide this exposure. Usually 4 sutures are enough to provide a good exposure. And here you can see the result with this perfect exposure. And in this patient, obviously the left atrium was gigantic, probably an old mitral disease. But when you have to do surgery on smaller atrium, like for example, in a mixed stem surgery, you have a pretty great exposure. We are done with the first part of this presentation. That was mitral valve exposure and access. So if you have some question, we'll be happy to answer.
Importantly, you have seen that we don't need any device for the exposure. We have no necessity to add some retractor, just some stitches are enough, and the exposure on the mitral valve is absolutely fantastic. There are no other way to get a better access on the mitral valve, and as you have seen, you have also the possibility to work on the tricuspid valve. You can do AF ablation on both sides. You can remove the appendage. So this is an absolutely perfect exposition for the valves. So,
Alexandra, I haven't seen any questions so far.
No, we have a first question from China, which is, does mini-invasive surgery in your centers and how many percentage?
The percentage is, I mean, for standard patient is 99%. We perform sternotomy when it is not possible to do minimally invasive approach, which is almost never for standard patient. Just when we have, as I told before, endocarditis, if you have lesion on the tricuspid, because it is sometimes a bit long to do on minimal invasive approach, the mitral valves and the tricuspid. But on minimal invasive approach, you can do the AF ablation very easily. The exclusion of the appendage can be done very easily. When we have severe patients where there is a risk to have difficulty for weaning out of bypass, when we have complex cases, I prefer to avoid the minimal invasive approach. So, but for the indication we have in my country, which are very early in the early stage of the disease, we often operate asymptomatic patients with dystrophic disease, and in these instances, the indication is almost always minimally invasive approach. So in this patient, as you on the movie, we had to do the tricuspid, mitral, the patient had a poor LV, and so in this instance, I prefer to go straight forward and don't pay to not to do minimally invasive approach. But it's not that frequent, according to the type of recruitment we have in France in my institution.
Okay, we have three other questions. The frequency of AV block. I think AV block is not a matter of arterial incision. It's more a matter of stitches that are taking close to the AV node during the annuloplasty. So and we'll discuss about it later if we still have time.
I think the question concerns the Giraudon approach, and this question it's a very important question to address, because when we cut we are very close to the sinus node, and we have evaluated this technique, and there are other people who have published about the Giraudon approach, but if you are far from the sinus node, when you cut, you are not on the superior vena cava, then you have no more AV block or sinus node disease after this kind of approach. So the Giraudon approach is very safe, including, the risk of AV block, which is very low. So don't be afraid of this risk if you have to do Giraudon approach.
And what about arrhythmias afterwards?
No more. Well, you have seen the patient in my institution. The rate of pacemaker after mitral valve surgery, even after Giraudon or after any kind of mitral valve surgery, is a few percent, very, very few percent, and it's only when you have patients who are old patients with previous conducting problems. But this is not a real risk. There are risks, but this one is not very, very frequent.
Okay, the last question maybe was, what kind of complication did you have after this Giraudon access?
Well, if you pay attention, there are no specific complications. As Daniel told you, you have to pay attention on the roof of the atrium to keep enough tissue at a distance from the aorta, because if you have a bleeding, you need to add another point. And if you are too close to the aorta, it may be dangerous to go to the aorta. And this is the only problem. We may have some problem, but these are not directly linked to this kind of approach.
Okay, we'll move forward to try to keep time for other questions for other.
Yeah, you have also some question on the access for the ischemic mitral registration. What is your preferred approach?
So for ischemic, we decrease the number of indication first. So we have very few cases of for ischemic patients. And but the standard approach for us is always a Girondo, whatever, regardless of the indication of the MR.
Yeah, and today, if we have to treat a patient for ischemic disease and ischemic mitral valve regurgitation, the so-called functional MR, we go mainly for mitral clip, but with a highly selected process through the heart team. And but there are almost no indication for ischemic mitral valve repair, provided they have another indication, meaning revascularization, meaning something to do on the tricuspid valve. And in these instances, the Girondo approach is very elegant and very efficient because you have a nice exposure. Because very often on ischemic disease, the ventricle are not, the atria are not that much dilated. We may have a dilated ventricle, annulus, and to do a downsizing annuloplasty. And here, if you try to do the annuloplasty through the groove, the exposure on the mitral valve is not that good. It takes a little bit more time to do the Girondo approach, but the exposure is so much better than you save time doing the repair. And more important, the quality of the annuloplasty you do is much better. This is why, even for ischemic disease, we prefer to use the Girondo approach. Again, the key for a good repair is to get a good exposition. And even for ischemic patients, they deserve to have a very well annulus implanted, because sometimes when you are downsizing annuloplasty, you may have recurrence because you have a detachment of the ring, because the ring has not been well implanted. So this is why the exposition is so important, and why for this first webinar we wanted to concentrate a part of this webinar on this exposition problem, which to us is very, very important.
Okay, I'm sorry, we have to move forward because we already reached more than half of the time we had for
Yeah,
this.
sure. Just before I leave you to continue, I'll just to share with the other people we ask many questions, that we will make some kind of Q&A at the end, and so there will be a lot of answers.
Yeah, okay, so we'll go pretty fast on that, the valve workup and lesion assessment. So as you all know, the mitral valve has to be assessed in its whole. All the structures have to be assessed to provide a good repair. Obviously, you have to assess the leaflets, and you have to and you also have to keep in mind that every repair should also take into account the opening function of the valve. When you do a repair, you have to have a good closure, but you also have to keep in mind that the valve has to open in a proper manner. We are giving a proper attention to the only rigid structure of the heart, that is actually the mitral annulus, which is part of the cardiac skeleton, and we know how much is important. We know that the structure from in between both triangles is the more rigid one, and that will be super helpful for the surgery. And we also know that there's that we will have to give a dedicated attention, for the relationship between the aortic valve and the mitral valve, because those two valves are super close, and this anatomical relationship was be in our minds to provide good repairs. This is
just to mention that the risk to take the nadir of the non-coronary sinus is a real risk. This is something which can happen. I have had this kind of complication, and I'm sure that any surgeon who perform annuloplasty can get this kind of complication, because sometimes the ring, you see the nadir of the ring is sometimes very close to the annulus, and the annulus is not always easy to see where is the border between the leaflet and the ring itself. So this is why this is a real risk, and you have to keep this in mind and pay attention to this when you put your stitches in this place.
We'll speak about annuloplasty in the very few minutes. So this is the great picture of the subvalvular apparatus, and and this is also a thing that you have to explore and you have to have in mind when you do mitral repair. So Professor Obadia, what are your the way you proceed to your valve workup?
Well, you know, we have to keep in mind what Alain Carpentier said so many years ago. The reference point is P1. You know, the prolapses of P1 is very uncommon. So as you see here, you start by the assessment of P1. It may happen. Sometimes you may have prolapses of P1, but it is not frequent. So this is the reference point. And it is very helpful because what you need to know when you do chordal shortening, when you do chordal replacement with neochord, which is today a very common technique. Don't go into details today, but you need to get a reference. So the assessment starts with P1. P1 tells you what should be the distance for any chord and where should be the free edge of the posterior leaflet. And then, according to this reference point, you have to imagine where should be the other part of free edges of the other part of the leaflet. And then if you have to repair, you will use or transfer or on the chord in accordance to this reference point. Then for the exposition, you can put stitches on the commissure and also the trigons, and also the trigons. And this is a nice way to have the valve facing you, because sometimes there is some angulation between the valve and your eyes, and it is a good way to put the mitral valve in regards of your eyes. And afterward, you can put your stitches. You see here, and what is the water test. And if you do, we will discuss that in another webinar, but so far we can already say that when you have the water test, you need to have this line on the posterior part. You sometimes, when you have, particularly when you have Barlow with huge posterior leaflet, you may have this line here. But if you have this line too anterior, this is a bad thing. This is the situation when you have a high risk to get a SAM after surgery because the posterior leaflet is too wide. So you need to have this smile very, very low in close to the posterior part of the ring.
And so in terms of mitral lesion, we won't go to all the basics of the interpretation of the lesion. Obviously, we use the Carpentier classification to classify the patient during the surgery, thanks to the location of the leaflets regarding the plane of the annulus. And so in France, most of our patients are degenerative patients with type 2 lesion because of the excess of motion of leaflet. Could be often is chordal rupture in a fibroelastic disease and or Barlow diseases.
With the Carpentier classification, there is one way which is very easy to describe a valve. And for instance, this one, excuse me, this one can be described as type 2 P2. This means type 2, there is an excess motion of one of the leaflet, and P2 means it involves P2. You may have also type 2 P3 or type 2A2. So this is in a very short term, you can describe very precisely mitral valves. This is why this classification is very convenient. Very often when you have a type 2, it's also type 3, also type 1, I mean, that is to say you also have an annulus enlargement. So the most common situation for dystrophic disease is type 1 and 2, P2.
Okay, and I think we had one question already in the Q&A about the importance of the pre-op echocardiography. So Professor Obadia, uh, do you watch the echocardiography in the pre-op in the patient, or is it just during the surgery? What's your advice for that?
Well, to be honest, the dystrophic disease is very often the same situation as I just mentioned. Type 2P2 represent 80% of the cases of dystrophic disease. So very often when the transthoracic echo is enough and described perfectly well, you don't need to have a TE even in the assessment before surgery, because what you want to know is, do we have or not to operate the patient? As soon as the indication is there, there is no more reason to go for the TE, because you know that when you do surgery, the first step is the TE. So when the patient sleeps in the OR, you spend some time, and this is very important, and very often surgeons go straight forward to the incision. This is not what we have to do. The first step in the surgery to spend some time with the echographer and to go around and try to see what are the lesions. I mean, the anatomic lesion, because in the OR, the assessment of the severity is sometimes not very relevant, because the patient is sleeping and the hemodynamic is different. But the anatomy is very well analyzed in the OR with the TE. This is the first step of any surgery. Then you repair the valve according to the lesion you have assessed during the TE. And at the end, of course, you reevaluate with the TE the quality of the repair you have just done, and you have to be very exigent on the quality of the result. If you have not a perfect or sub-perfect result, you have to go back, and the patient it's mandatory that the patient, when he leaves the OR, the repair is perfect.
I guess we can identify two kinds of patients. You've got all the, what we will call the simple patients, yes, who are outgoing patients sending from cardiologists outside of the hospital, and we rely pretty much on the pre-op TTE, and we can go to surgery with only a TTE, even if we don't see, we haven't seen the lesion before the surgery, but we'll see the lesion during the surgery because of the TE, the intraoperative TE. And for all the most challenging cases, we have what we call a structural valve heart team, and we used to go to the echo lab and to watch the lesion with our cardiologist, and for this patient ask the question about the innovative treatments. And I think that the expertise in echocardiography, even for surgeon, is super important now, that there's many different ways to treat the valve, and you have to understand what you are seeing, because otherwise you can't know what you need to do for them.
Yes, and I prolong what you just said, Daniel. When as soon as you have any hesitations, TE is mandatory, because we need TE if we have to decide if the patient should be referred for surgery or mitral clip or prosthesis, tendine, for instance. And in this evaluation for percutaneous technique, we need a very accurate evaluation to decide whether or not it is an anatomy suitable for this typical indication of percutaneous technique. But you see, again, for the majority of the patient, the transthoracic echo is enough to evaluate. This represents 80% of the patients.
Okay, we have just two questions. Isn't it TE different after anesthesia? I think Professor Obadia already answered to that. The answer is yes. The hemodynamic condition change. Also, for example, the tricuspid valve, this analysis should be carefully done, because the diameter depends on the volemia, and so under general anesthesia, the diameter of the tricuspid is decreasing. So be careful with the interpretation of the diameters during this moment.
And this is why, when at the end of surgery, if you have let's say a type 2 regurgitation under general anesthesia, you cannot accept this kind of result. because you know that as soon as the patient will be awake and back to the ward, the evaluation will see grade 3 or even more, or even the patient will come back after 5 years or even earlier. So you just tolerate trivial mitral valve regurgitation after repair for dystrophic disease. This is absolutely fundamental. And one of the reasons is that you just mentioned, when you are under general anesthesia, the evaluation of the severity of the MR is always downsized.
Okay, and this almost answered to the other question that we had, that was what your approach for residual MR after correction. So I think that Professor Obadia answered. If you have more than trivial MR in the OR under TEE, you can't leave the regurgitation like that. So it's better to reclamp and to improve the repairs and going with a patient that more than a trivial residual MR. For post-operative residual MR,
just to, we have had some patient with this kind of decision. If you do mitral valve repair, even in the best hands, sometimes the repair is not perfect. And what means that you are in a hard team of expertise is when the surgeon who performs those kind of repair do not accept a suboptimal result. It doesn't mean that we have always a good result after the first attempt. And in my institution, sometimes we are not happy with the result. But what differentiates a team of expertise from another one is that we never accept suboptimal result. This means that we accept to reclamp, and we have had to reclamp patient after Giraudon approach. You can use the same incision. You have to pay attention when you repair, because when you go for a second step on the roof, there is a risk of bleeding. You just have to be very try to do the best you can do, but you have to be exigent on the quality of the repair.
Yeah, and sometimes you have to implant the prosthesis, I guess.
Well, that is, it was very rare, very rare. For dystrophic disease, we have to come back some years ago to go back to find one patient where the repair was not perfect. Well, after a second attempt, I mean.
Okay, we'll move forward to the last part. Alexandra?
There is a question of the suture, but let's leave at the end.
A question of?
Sutures.
On the suture, but let's leave at the end.
Yeah, so the last part will be the basics of the repair. Actually, it's very hard to speak about repair. We can spend years to speak about that. So we decided only to speak about annuloplasty. So, but just to put the annuloplasty in its concept, obviously we are doing the same than all the expert center for mitral repair. We do multi-targets repair, which means that the annuloplasty will be mandatory, but with either leaflet solutions like resections or a subarachnoid apparatus treatment like neocord implantation, and mitral annuloplasty will always be associated with one or the other technique, but never alone for degenerative disease, actually, most of the time, like in majority of time. But always keep in mind that it's just an additional technique to something else for degenerative disease. So a few words about the annuloplasty. The challenge of the annuloplasty is to have sutures that are far enough in the tissue to reach the rigid structure of the valve, that is the annulus and the two trigones. And we can see here in this anatomical description that the hinge of the valve, that is here, the part where the valve is moving toward the ventricle, can be somehow far from the rigid structures. Here, that is the annulus, and that's how you have to go like 1 to 2 millimeters away from the visual hinge to the tissue to have like a strong bite. But you always have to keep in mind the different anatomical elements that is surrounding the valve, that are the bundle of His, the aortic valve here, and obviously the circumflex artery and the vein. And sometimes in patients with right dominance of coronary dominance, the right coronary artery. And here you can see the same drawing. So you can see the hinge here, you can see the fibrous annulus here, and the coronary artery that is here. And depending on where you will be, you will have to pay attention to not going too far on the bite to avoid taking the important structures.
To mention the main risk, as you know, we all have complications. Even in the best team, we have complications. The difference between a team of expertise and another one is not the fact that you have or no complications. The difference relies on the way you take in charge the complication. And to be honest, the most frequent risk is the risk to get the circumflex artery. Not because you take the circumflex artery, so because sometimes some patients have different anatomies, and sometimes the coronary is few millimeters for the ring, and very often you don't take the coronary itself. I have had this kind of complication in my institution, and we have had some of them. Even when you are an experimented surgeon, you may have this complication just because the anatomy is different. And when you put your stitches, you may have a kinking. And you see that when you wean the patient out of bypass, and usually what we do in those instances, we leave the patient on ECMO, and we go to the cath lab, and in the cath lab, very often you just have to put a stent, because again, the risk is not to take, and we never take the coronary. It's just by chance, the patient has a different anatomy, and whatever the quality of the technique you use, you may induce a kinking. And this may happen in any of you and in any of us. The difference is the way you take in charge the complication. And if you go straight forward to the cath lab, you just put a stent and you realign the coronary, and you do that within the hour following the surgery, and the patient recover completely. So if you take in charge this complication accurately, if you anticipate this risk, because whatever the quality you will have, this risk remains. Because it depends not on the quality of what you do, it depends on some exceptional anatomy of the patient. And the risk you have also is to get the nadir of the aortic valve. This may happen. This is not frequent. This is not frequent. If you pay attention, this is not frequent, but this may happen. And the risk of heavy block is very, very few, because it is far from this place, and the bundle is a large area. It's not just one thing you can take. So this is not the main risk. Another risk is to take the right coronary when you have the dominant coronary artery, but this one is not frequent. So if you have to keep in mind, one risk is this one, and it is from P1 until P2. And this is an area where you have to pay attention. You can, when you can look at the coronarography before surgery, just to know if this is a patient at risk or not, or even more accurate, if you have a 3D reconstruction with an angioscanner, a CT scan, you can also evaluate this risk.
So in the service, we're using the PETERS sutures, the cardiac seal, that are appropriate for either repair and replacement. So for annuloplasty, for mitral repair and the annuloplasty, we use the suture without the pledget. For mitral replacement, we use the suture with the pledgets. And also, we are going to move forward to cardiofront that has been designed for the mitral valve, and that has some properties that are supposed to help us for tightening the node and for more resistance. In terms of sizing, you will find great discussions in conferences, in books, everywhere about the best ring, the optimal ring for the for any type of mitral degenerative lesions. I see already a question in the chat. I think we're just going to describe the technique that we are using here in our institution. But again, it's just a matter of choice, and it could be discussed for years, and it has been discussed for years and years. So just a matter of what we used to do. So this is a technique in our institution. We are first implanting sutures, usually 2 in both sides, in the commissure, and 1 more toward the trigone. And when you have that, you can do a perfect sizing of the valve. We use in the department only Taylor bands from Saint Jude. And the advantage of the Taylor band is that you can, after implantation, you can decide to leave it open or to remove a part, to cut it in the middle, and basically you can adapt the size of the annulus and its fixation all the time during the repair.
Yes. Well, I can add another comment, which is a very practical standpoint. I mean, why I like flexible wings is because I have re-operated on many patients, of course, and sometimes I have seen some colleagues who had put the rigid wing, not in the exact position. And to be honest, it is not always that easy to have the exact correspondence between this mark and the real anatomical commissure. So if you use a flexible wing, as you can imagine, if you have any distortion, as soon as you are removing the holder, you have the ring which is perfectly adapted. I don't believe that the ring is still flexible after the implantation, but what I am sure is that it's easier to implant. And if you remove the anterior part, of course, there is no more risk to get the aortic valve. And also you have a more important motion of the anterior leaflet. And this is why in most instances, I use this kind of rings. Of course, if I have to do ischemic the patients, the concept of remodeling is important. And in those instances, I prefer rigid wing. Well, this is an example. Here you can see the margin between and you have to be really on the position at the exact limit between the leaflets and the annulus. This is very, very important.
Also, I think we reached we finished the slide that we wanted to talk about. We are going to expect probably more questions. There was already question that was asked before the webinar. So here is some of the questions. We'll try to answer a few of them. About the preoperative echo, I think we already answered. The exposure of the valve, we spent some time to speak about that. The choice of surgical method for beneficial long-term survival of patient, rather respect or resect technique. I think this is what this question refers to. For this question, I just brought a lot, the result of a meta-analysis I liked a lot because it concerns a lot of patients and pretty recent studies. And we can see here the freedom rate from operation between resection and resect and respect technique. And I guess for experiment teams, the answer is that basically, if you do well what you know to do, you have great results.
Yeah, I think you have to be used to a technique. It's difficult to say that if one technique is better than the other one. For sure, caudal shortening, and even Carpentier himself said that with this technique, you have a suboptimal result. And you can understand that if the chordae is elongated, it is no more available to get a long-term and durable repair. So, but I like the neocord implantation because It's an easy technique, and it is very reproducible. The only difficulty is to assess the length of the chordae. It would require another video. We should discuss that in another webinar, because it is a very long. It takes some time to discuss that, but we try to assess very precisely with preoperative echo, and also with in correspondence to the distance in P1.
Okay, other question about the leaflet cleft repair method.
Well, we have to pay attention to the definition of a cleft. A cleft is a cleft. The cleft is a congenital disease, and very often it's very easy to repair. We just have to close the cleft. It's on the anterior leaflet, and you close the cleft, and then you have to choose an annulus to secure the quality of the repair. But sometimes people, when they say cleft, they mean indentation. Indentation is what you have between P1 and P2, and between P2 and P3. And if you repair complex Barlow, you have some indentation in different places without any correspondence to the normal anatomy. And very often, you don't need to touch those indentation. If you just, for instance, if you have a type 2 P2 prolapse, again, 80% of the cases, if you put good neochordae in the right position, usually I put 2 chordae on the posterior leaflet, 2 on the posterior papillary muscle, 2 on the anterior. That is to say 4 chordae on P2. This is enough, and you don't need to close indentation. You have to keep in mind that those indentation belongs to the normal anatomy. So there is no reason not to leave those indentation, because sometimes if you want to close those indentation, if you take too much tissue, you can create regurgitation because you track too much on the toe sides of the indentation. So the less you do, the better.
Okay, but technique of repair for difficult pathology, I think it's a matter of another webinar. And for this last question, what you do if you have a good saline test but a bad TE, I think we answered again. The TE is super important, and if you don't have a good result at the intraoperative TE, you have to reclamp and going back to surgery.
This is the case when you have SAM, because when you do the water test, the anterior leaflet always go posteriorly because you feel the heart. But the water test is unable to detect a SAM, to anticipate that you will have a SAM afterward, because the SAM is a consequence of the dynamic of the ventricle. So the SAM is not seen before you unclamp the patient and the heart beats. So the way to assess if you are at risk of SAM or not when you do the water test is what I told you before. You need to have the smile behind on the posterior, close to the posterior part of the ring.
I think we have an interesting question here. Do you have any concern regarding remodeling after LV after a successful mitral valve repair in degenerative MR? Do you make like longer chordae because you know that there's going to be remodeling, or it's not a matter?
No. The risk to have too long or too short chordae doesn't exist if you put your chordae on the papillary muscle, because in the normal physiology, when the heart decreases its size, the papillary muscle decreases. So there is a compensation of the decrease of when the apex of the ventricle comes towards the plan of the annulus, then the tip of the papillary muscle go in the opposite direction. This is why there is no risk to have, if the ventricle shortens after mitral valve repair, which is almost always the case. And you see that 1 week after, when you re-evaluate the patient, the ventricles are always decreased. So this risk doesn't exist. This risk exists for when we have done neochordae. I mean, the technique of neochord through the apex with left thoracotomy. In this instance, the risk exists because the chordae go from the free edge of the leaflet to the apex of the ventricle. This is a long distance. Usually a chordae is 15 millimeters. This is the mean length of a chordae. But when you go from the free edge to the apex, it's sometimes 6 centimeters. And in this kind of patient, we have had in our series with Daniel, 2 patients who had a decreasing LV dimension and a recurrence of the MR, and one of them had to be reoperated on to be corrected for this valve. We also had this kind of problem with the tendine valve, where, as you know, the tendine of the tether, and this is the same risk. But this is because we discuss of a distance between the plan of the annulus and the apex of the valve. This is no more a risk when you speak of the distance between the valve and the tip of the papillary muscle.
I think we are close at the webinar, and maybe we can finish with the latest question. You know, you explained the couple of minutes that you use, or you know, and Cardioxil recommend and Cardioflon for the annuloplasty. There was a question on the elastic suture, you know, Cardioline, which is more dedicated on the repair of the valve. In this process of leaflet repair, how do you use or how do you recommend the elastic suture in order that it's helpful to the patient at the long-term prognosis, or will it reduce the incidence of the post-operative complication?
Well, it's difficult to answer to this question. You know, everything is important in mitral valve repair, the ring, how you size the chordae for the Gore-Tex neochordae implantation. The stitches you use is less important, even if any detail is important. But I will now answer to your question. I think that if you have flexible stitches, it's easier. It's easier because you are less aggressive on the tissue, and since it is dystrophic tissue, you may have some dehiscence or tear on the leaflet itself. So to have this elasticity is helpful. It's not you can do with any stitches, but the elasticity is interesting to decrease the damage on the leaflet, and it will also helpful because sometimes on video when you tie the knot with a pressure knot, sometimes you can block the stitches. So if you before you ask it is tied enough. So with the pressure knots, it's easier to have flexible stitches. But again, this is a detail, an important detail, but it may be helpful to get a good repair. Daniel, you want to add something?
No, I think.
So thank you, Professor Obadia. Thank you, Dr. Grinberg. I think we will end this session because now we are over the timing, but that means that many people ask for questions, and we have still some questions, so I may share with you, and we can send back to the whole of the people. So I will first thank you, all of you both, for the high quality of the expertise that you accept to share with the attendees and the time that you allocate. This seminar is registered, and we will share this seminar as a replay with the attendees. And if you mind, if you can answer some question, it will be pleased that we send as well. We will send as well some survey in order to know all of you if you are, what about the satisfaction about this webinar, and if you want to go continue maybe after summer to do such a different topic or additional one.
Thank you for the organization again, and we are very happy, Daniel and I, to share our expertise and our passion for mitral valve repair. And again, it was a pleasure to be with you, and thank you to PETERS and your team for this organization.
Our pleasure, and have a great end of day, and we hope to see you soon on the next webinar.
Thank you.
Thank you.
Bye-bye.
Bye.
Bye.